to the Public Health Practice Grand Rounds for November 2009. My name's Molly Mitchell, and I'm the coordinator of the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Maryland Department of Health and Mental Hygiene, I'd like to welcome you to today's presentation of Who Will Keep the Public Healthy in 2020, Strategies to Develop the Public Health Workforce. Before we have our presentation today, I'd like to invite you to visit our website and view our upcoming trainings, which include our core competency training series with Dr. Carolyn Fowler, including community assessment and formative evaluation in Baltimore on December 4th, influencing decision makers through social marketing in Howard County, as well as practical grant writing in Washington, D.C. on January 6th. Our website also includes archives of previous grand rounds, including the update on H1N1, social marketing and public health, and many others. Please note that our usual public health practice grand rounds that occurs every third Wednesday of the month will skip the month of December, but we will come back again on January 20th, 2010. And for those of you watching online, we invite you to sign in using our online form and to email questions that you have to the presenters at any time during the broadcast to maphtc@jhsph.edu. And with that, I'd like to introduce our speakers for today. First, we have Earl Stoner, who's a health officer for Washington County Health Department. In this role, Mr. Stoner determines the public health needs of the county, designs programs to meet these needs, enforces the health laws of the state of Maryland and local government, and directs the Washington County Health Department. Mr. Stoner received his bachelor's degree in community health from the University of North Florida and his master's of public health from West Virginia University. Mr. Stoner has worked for the Washington County Health Department for over 16 years in various capacities. His career has long focused on community health issues, particularly for underserved populations. His experience includes coordinating the implementation of health initiatives at local, state, and national levels, as well as managing community-based preventive programs. Mr. Stoner is a lifelong resident of Washington County and holds positions on numerous boards and committees. He currently serves as chair of the Walnut Street Community Health Center Board. Our second speaker today is Dr. Henry Taylor. Dr. Henry Taylor is currently faculty at the Johns Hopkins Bloomberg School of Public Health in the Department of Health Policy and Management. He spends half his time on public health systems research related to community partnerships and chronic disease. The rest of his time he spends as clinical deputy health officer for Cecil County or teaching internal medicine residents and curriculum development at Johns Hopkins Bayview. Dr. Taylor is trained in general internal medicine as well as being in the inaugural group of Certified in Public Health. He and his nurse practitioner wife started an innovative community health system in the mountains of West Virginia where he practiced as a modern country doctor. After 13 years, he returned to Hopkins for his MPH. While still a student, he was recruited to be West Virginia's state health officer under 3 governors and 2 political party changes. He left that job to address what he saw as the most pressing public health issue: who will keep the public healthy when we're gone? Earl?
Thank you, Molly. Okay, let's get right into this here. So what I want to speak about today is really developing the local workforce at that grassroots, rubber meets the road level, in the general theme of like developing that core workforce that's currently there, and in establishing pipelines for keeping individuals interested in public health and coming into that workforce. And I want to start off today with a quote that I thought was rather striking and really exemplified what we're going to be speaking about today. It's from ASTO, the Association of State and Territorial Health Officers, from their 2007 Public Health Survey of states. And it's basically self-explanatory. Unfortunately, public health workforce trends continue to indicate a waning of this vital resource. And given that that's now almost 3 years old, we see that as we speak today, Maryland will probably undergo more budget reductions, specifically to health-related activities, which unfortunately will probably result in even further decline in the workforce that we have, especially at the local level. So what's the issue? Aging and shrinking workforce. If you look at some of the statistics nationally, we as public health system in this country have lost about 15,000 jobs over the past 2 years at the local level, and an additional 12,000 were subject to reduced hours or being furloughed. About 250,000 more public health workers will be needed by 2020 to replenish what we're losing now. And currently, if you look, about 20% of the workforce nationally is eligible to retire in 2010, next year. And if you look at 2012, that number jumps to 50%. And at least from my perspective, as we continue on, like what do we need, especially in a time when, an environment when our most critical resource is shrinking, which is the workforce. We need to be more efficient. So efficiently in public health operations is number one in my book, and I think that we really need to prioritize that. We're looking at lack of training in public health principles. We have a current workforce and a potential workforce that needs to have sound public health training. What are the core functions? What are the 10 essential services? We hear evidence-based, like what does that mean? Lack of job-specific training, skills training, another key issue, and you could break it down from a management level down to the lower end frontline workers. Like, what is my job, and what specific skills do I need for this job, and providing that to the workforce. Lack of succession planning. I think this is grossly overlooked, and we'll hear more about it with Dr. Taylor's presentation. And a need to just be efficient in the use of our resources. I mentioned staff, but also training, and also just from an operational perspective. So efficiency is the key. What I did with 10, 20 workers a year, 2, 3 years ago, now I have to do with 5, and sometimes even less. So it's critical that we focus on our existing and our future workforce and make sure that they have the skills to perform their jobs and their roles more efficiently. So kind of piquing my curiosity and sort of setting me off on the workforce trend and exploring it a little bit more as I came in to my role as health officer was I had the good fortune to be a part of a group from Western Maryland, and I'll specifically mention the group that I worked with was from Western Maryland Health Departments of Allegheny County, Garrett County, of course my own Washington County, and Frederick counties. We were a part of a group of scholars with the Hopkins Mid-Atlantic Health Training or Leadership Institute, and the project that we chose as a part of that was to really look at the workforce at our local health departments and establish a baseline of who do we have, how many years have they worked in public health, what are their skill levels, and from their perspective, what additional training do they feel as though they need in order to bring their competency level up or their skill sets up. So we really looked at establishing that baseline and then developing recommendations to enhance their skill level and the effectiveness of each of our health departments' workforces. As I mentioned, there were 4 local health departments involved in the group that did the assessment. And all in all, we had about 48% of the employees at our respective 4 health departments that took part in a survey. It was a web-based survey and through SurveyMonkey, and or if individuals didn't have access to the web, they could take it through hard copy. Some of the key findings, the key highlighted findings was about a third of the workforce had over 15 years of public health experience, and 52% of that workforce had less than 5%. 5% at the time were currently eligible for retirement. 22% will be eligible or would have been eligible for retirement in 2012, and then 40% being eligible to retire in 2017. And about 2% held a master's in public health. And all in all, the workforce confidence was low in relationship to their individual skill sets and job duties. One of the things that we tried to do, in addition to just looking at those specific duties that you have to perform while you're employed at the health department, we tried to also link it with some of the core competencies. And that in and of itself was interesting because honestly, most people were unaware what any of the core competencies were. So some of the recommendations that came out of that were more structured public health principles and core competencies training, really looking at getting to the root of this is why you're here, this is what public health is all about, and as a worker within this system, not specifically just at this health department, these are the core skill sets and the core competencies that you're going to need. Looking at the possibility of implementing interactive modules. I know that some states and some local jurisdictions out there currently have this, but really looking at more of a Public Health 101, 102, and 103 type module series, going from a basic level to a more focused managerial or supervision type of level, and then getting into evidence-based program development and policy development specifically, but across that paradigm, really nailing down like what's the science behind what we do, bringing that research component in. How can we get more bang for the buck? You know, we've done X for a number of years. Can we do it better? And what does research indicate? Another recommendation was fairly obvious to us and something that we in Maryland have the good fortune of being able to do, specifically with Johns Hopkins, University of Maryland, and having linkages with academic institutions and other public health organizations to really get into, you know, this is the training or these are the skill sets that our workforce is indicating that they're in need of, working with these entities to provide those types of trainings, such as what we're doing here today, Grand Rounds, working with the Mid-Atlantic Public Health Training Institute, and providing some of those core competency type trainings. The third recommendation was development of departmental orientation plans, getting into learning objectives, hands-on application, and really focused on building those skills. It's great to stand up here and talk about it, but like, what are we going to provide the workforce from a skill level perspective? Like, what are they going to take from this? In essence, what are they going to take home? We have to give them something to apply. And so often we go through trainings and conferences where we, you know, and not saying that it's bad, but we listen to a lot of lectures, but we have to give something for the workforce specifically to take home, to take back to their respective health departments, whether it's state, local, and actually apply. So orientation to local department programs, services. I know specifically within my health department, and even to this day, even though we've been working on it, you know, it's that right hand, left hand. Sometimes the right hand doesn't know what the left hand does, and sometimes the left hand doesn't know what the right hand does. So really orienting your staff to this is the health department, and this is what we do. Doesn't matter if you work in nursing, doesn't matter if you work in environmental health, you're part of this system. You're here to do this, but you're still part of the overall picture, and it's important to know what that overall picture looks like. Having regularly scheduled supervisory sessions for follow-up, staying in tune from a management or a supervisory level with those frontline workers, continually assessing those needs and getting feedback from them, and then obviously having opportunities to attend conferences, trainings, and to build those skills to bring back. So in conclusion, the assessment really showed that workforce confidence in their ability to perform their job duties in relationship to several key public health essential services was low. The workforce felt that additional training was needed, obviously, in order to enhance their job skills and in order to enhance their skill sets, and that further study was needed. You know, our study wasn't without limitations, as no study really is, but further study was needed to really nail down specific workforce needs, recruitment and retention issues, and those sorts of things. So what are we doing specifically at my health department? We took from this baseline survey the understanding that if we wanted to get serious about building a workforce, we needed to prioritize workforce development, which is what we did. Some of the overarching themes of our plan or of our actions that we're taking is really looking to strengthen our agency's workforce, build their skills, build that competency level so that we can honestly say we have a competent local public health workforce, enhance knowledge, enhance their skill sets, give them something to take home, give them something to bring back to the agency to apply, and then developing a succession plan for agency leadership. First in that specifically is, as I mentioned, recognizing that we're basically in a crisis. We've been in a crisis in public health for some time. As I mentioned before, and as you'll hear as a repeated theme, the workforce is shrinking. 5 years ago, it was basically due to aging and retirements. Now we had the added layer of reduced funding, which amounts to layoffs, specifically at the lower level. I don't think we're unique in that, as from a local jurisdiction's perspective, the predominant amount of fiscal resources that we have at our disposal goes to staff. We obviously have money devoted to line items and those sorts of things, but we're basically the individuals that see the people that come through the door. You need staff to do that. We get into policy setting and policy development and those sorts of things, but at the local level, that's where you have the critical mass of staff who actually implement those programs. They sign people up for MCHIP, medical assistance. We actually go out and do the PERK test. We see people in our STD and our family planning clinics. So not to say that we don't branch outside of that firsthand frontline service administration, but predominantly that's what we do, and predominantly we're staff. So any cuts that we sustain obviously have a direct impact on the level of workers that we have. So creating that awareness, like workforce is a priority for us, and making it an agency priority, not something that, well, yeah, as an agency we need to look into that. You need to prioritize it. This is my little flag coming in. And that's not the surrender flag. I couldn't change the white, so don't take that in the wrong way. Not yet, at least. Number 2, overseeing the development of plans for workforce development. So we've prioritized it. We've said, yes, this is a major priority for us. Now what are we going to do? So we looked at overall and overarching strategic planning. We are in the process now of finalizing a strategic plan for the agency. And some people may think, well, what's that have to do with workforce development? One of the biggest things that we did was we looked toward empowerment of the workforce, empowerment of the existing staff that we had. We went through a process of redefining our organizational culture, predominantly through establishing and sort of revamping shared core values, beliefs, goals, mission, vision, all of those buzzwords that you hear. We went through a process of having the entire staff involved. We had a 2-day retreat for management and for selected staff who were able to take part, and we also sought input through a web-based survey that we conducted. So all that feedback came back into sort of like the shared vision, the shared core value, the shared mission, and all that sought to obviously give us an action plan of where we want to go and how we're going to get there, but also from an overarching theme perspective to empower our agency and to sort of be that first step in getting us all on the same page. We are in the process of establishing, as part of the strategic plan, a workforce development committee. That committee obviously will function as any committee does, and really looking at linking our activities from the strategic plan into workforce development. And most importantly, from a composition standpoint, we really want to get representation from a cross-section of employees. We don't want it to be management heavy. We in management so often think we have all the answers, and we have the idea and the answer, and this is how we're going to do it. But a lot of times we aren't on the front line. And if we were, sometimes we were on the front line a while ago. And so we need to continually have every aspect of our staff involved in these types of activities. Skill-based and competency training, as I mentioned, really establishing a public health overview. I really, if there's one thing to take away from this, it's that, what is public health? What are the core functions? What are the essential services? Until I went back to get my MPH, that I went back to West Virginia, I mean, I was at a managerial level within my health department for several years. I couldn't tell you what the core functions were. I didn't know what the essential services were. I didn't know what evidence-based practice was. So it's critical as we move forward that we're providing opportunities for our staff to gain this knowledge and this expertise. Obviously, a health department overview goes back to that left hand knowing what the right and vice versa is doing. And then individual skills development, professionalism, phone etiquette, customer service, just those basic job-specific skills. Because it's great if you have good phone etiquette and if you're the ultimate professional and you work at the local level within the public health. But if you don't know really why you're there, it doesn't complement, and vice versa. It's great to be the world's guru on public health, and I know the principles, but if you don't have good customer service skills, and by customer service we mean internal and external. It's not just picking up the phone and saying, hey, this is the health department, how can we help you? It's also working well with colleagues. It's also working together as a team. Training opportunities, self-explanatory, external workshops, conferences, leaning more and more toward obviously distance learning, web-based activities such as what we're presenting today, and obviously then internal trainings. We may not have enough money now to send 4 people to a training, so one person may go and bring those skills back, kind of like a train-the-trainer concept. Focus on recruitment and retention. Some of the things that we have done is myself and another member of my staff were part of working with the Department of Health and Mental Hygiene, which in Maryland is a state health department, and looking at retention and recruitment issues. Some of the things that were explored were compensation issues. The department did a compensation survey, which showed us a lot of things. We're state workers, so we obviously don't make as much as they do in the private sector. But there are still some things that we can do from that standpoint. Obviously, in lean times, this is probably not the time to really explore that. Retention survey. There is talk of doing a retention survey, finding out why are you leaving, why are you staying, what are some of the things that we can glean from that. Hiring practices. One of the things being in state service is that from start to finish it can take a while bringing an individual on. It's not unheard of to, for instance, need to hire a nurse or a nurse supervisor, and 3 or 4 months later you're finally finalizing that process, so to speak. So looking at our hiring practices as a state, which affect hiring at local levels, and really refining those. And then last but not least, one of the things that my health department that we have recently implemented was exit interviews. And some people might think like, well, why do you really want to know anything about that? Well, why are people leaving? Is it because people are retiring? Is it because people feel as though they're not making enough money? Salary and benefits could be an issue. Was there an issue with the manager or supervisors that they had that we as management then need to look at? Were there limited promotional opportunities? I think one thing that we also need to stress today is career development. I know Dr. Taylor will get into that a little bit, but career development is very important. Piquing that curiosity, getting individuals in a position where they feel as though there are opportunities. Not squashing or limiting individuals' ambition or their sort of like the lights that go off in their head. It's great to have that, but if you can't move up the ladder, at some point in time I'm probably going to leave and go someplace else. And last but not least, and probably most important from a managerial standpoint, is establishing a succession plan. We haven't actually done this at my health department now, but we were working in this direction until good old H1N1 flared up. So now, obviously, like everyone else, a lot of our resources are combating that. But when we come back to these activities, really establishing a succession plan, linking our strategic planning and workforce decisions together is critical. Analyzing the gaps. Where are we? Where are we as management? Where are we as a department? Do we have interest amongst lower level employees in career development, in moving up that ladder. You're never going to know until you do an analysis. You're never going to know until you ask. And identifying those talent pools. Then developing strategies. Well, we know all this. Now what are we going to do about it? It goes back to that paradigm of like it's good to talk about it, but put it into action. Implementing those strategies, and then, of course, monitoring what you're doing and doing an evaluation of that. Overseeing the evaluation of workforce development. So as a plan, as succession planning, creating opportunities for trainings, skills development, prioritizing the workforce, we really need to, as an overarching view, continually evaluate that, which is, from my perspective as the health officer, one of the essential functions of our workforce development committee. Basically get this ball rolling, but once it's rolling, ensure that it's rolling and it's rolling effectively. It's not zigzagging, it's not bumping. We need to make sure that the ball's rolling and it's rolling smoothly down the road. Everything that we implement initially, is it going to work? Probably not. I don't know anyone who initiates anything and it's just a perfect solution, it's the perfect plan, and it's just working effectively. So monitoring it and really determining, what are our needs? What we plan for from a needs perspective today, 2-3 years from now, could be different, and hopefully will be different. Have we been successful? What's our definition of success? And can we do something more effectively? So from my perspective, they are the critical elements in workforce development. But the central point is, if I can just sort of think about it here, just from an overarching perspective, it's getting people interested, raising awareness from a local jurisdiction, state jurisdiction, a private foundation's perspective, whatever you may be, prioritizing. And prioritization isn't saying, well, this is important to us. Prioritization is actually establishing a plan, putting action steps to that plan, and actually doing something. As I mentioned before, I can't say enough about it. We so often say we're going to do something, we never follow through with actually doing it. So in my mind, prioritization isn't the act of saying it is, it's the act of saying and then doing something about it. And then monitoring what we're doing. As I just mentioned, what we're doing, is it effective? Is it actually building our workforce? If we're seeing the same types of trends as far as individuals leaving as we had before, maybe we need to reevaluate what we're doing. So from a global perspective, raise interest, prioritize it, set an action plan, and monitor and evaluate. And I thank you. Dr. Taylor.
Thanks, Earl. Molly, I know you're tracking computer stuff. Are there any questions or anything that have come in at this point, or we'll have discussion later? So just thank you, Earl. It's really good to be here and to follow on with this project. I really think that what's happened with the scholars, this group of leadership scholars, took on this issue and really did a marvelous project focusing on what was real for them and keeping your focus on that. So I hope we have some time in discussion, because I'm hoping a lot of our audience from out there as well as here in the auditorium want to talk about sort of the career and career path and pick up on some of these themes. But in working with Earl's group and then with the training center and a number of projects over the last years, I wanted to share my thinking related to succession planning. And I think Earl was saying, well, we haven't gotten around to the succession plan, but I think he is. I mean, the time's being spent on thinking about the organizational culture, getting the climate ready to act, is what I think is the first step in that planning process. And one thing I like working in local health as well as on the academic side is that sense of taking theory into action, making it work. So I wanted to really focus here for my section on this question that I I personalized it a little bit more than the larger title, which is, who will keep the public healthy when we're gone? Sounds sort of like maybe a country western song, but I do think it's that personalization. I wanted you all to think about it at that personal level. We are all doing public health. The mom in the middle of the night is doing public health. You could go on with all those lists of what is done. And there is an institutional base and a memory that has had tremendous impact on health. It's different from the sickness services that are provided across the street, and we do some of those. But who will keep the public healthy when we're gone? How will the public be facing the next pandemic? Not just this one, but the next ones. What is that, and what are the skills that are required, and who are those people? Because, as Earl was saying, in general, it's 70% of your public health dollar is going into the people. And if we don't have the right people for the right jobs, we're wasting what precious money we have. Not the part of me that's a state employee, but the part of me that's an academic, fully understands the pain and the stress that the administration, the current Maryland administration, is having to go through at the moment with their budget cuts. In order to balance their budget, they've had to impose cuts in the last quarter of last fiscal year, and again in the first quarter of this fiscal year. And today, I think there's going to be some other news, and it's not going to be pretty. And so in planning this, we said this might be the worst time to do a talk about workforce and strategic planning when everybody's just trying to hunker down and survive. I mean, the impact on some of the programs at the state or county levels may be 1/3 to 1/2 of the employees, the FTEs, are being cut that dramatically. Could GM and Ford operate that way? Could businesses, could the School of Public Health operate that way? So how do we incorporate that thinking? I think personally it's not the time to just tighten the belt a little bit tighter. It's a time to fundamentally think about what we're doing and why, but building the boat while we're sailing it is okay, and we don't have time to do anything else. So Earl led off with a real statement of the problem in the western counties, in the counties of western Maryland, and those issues, and gave that project had a very clear handle on it. This is from National Association of City and County Health Officers, their latest survey in 2005. And at the national level, health departments are reporting current or anticipated problems in selected occupations. So the nursing, the epidemiology, environmental health, health educators, IT, they are very great problems that are facing our public health system. And these are the people who bring you clean water, vaccinations, the things that really make a difference. So I just say that to generalize that the problems we're facing at the microscopic level are not limited to any one place, but they're actually global. So what are the challenges? And I think Earl did a great job of covering this. The breadth of the knowledge. We are having to move workers around. People think of government in the Reagan years as being monolithic. It is actually very fluid, partly because the only way you can get a promotion is to switch to another job in government. I think it was a wise person told other people it's like Brownian motion, that government workers are always kind of bouncing around and how to seize that. And government can't give the merit pays. So all of those problems are compounded by an aging workforce. And at the Public Health Association talk, there were even presentations about the work style of Generation X and Generation Y, and now they're talking about Generation Z, which are the kids in elementary and school, and the patterns and the belief and the culture they grow up in and the way they work and do business is very different from those who went before us. So my focus here is on, this is the end of my talk, a system that succession planning is really this systems thinking. It's a systematic approach to ensuring that an organization has a steady and a reliable pipeline of talent. Wouldn't that be wonderful? I mean, this is how the business people think. It's like steady and reliable pipeline. Wow. And they are ready, willing, and able. And in the Preparedness Center, people are doing some work on this, that readiness, it's like the truth, the whole truth, and nothing but the truth, that ready, willing, and able are actually different components of the same concept. And our ability, often we focus training, like in school of public health, we have people who are willing and we give them the training to be able, but are they really ready? It's almost a gospel song there. Are you ready? I mean, what is it that is that readiness to go forward? And one thing that I'll talk about later, an organization shouldn't move forward until it's ready. And the readiness to do the essential functions of that organization, and I'll come back to that, because what are the essential functions? This is what the business mindset has been able to do, not the corporate things that led to the collapse of Wall Street. But business has grown because it keeps its focus on its essential functions, particularly in its leadership and in the linchpin roles. And again, to go to the heart of what the work I've been doing is about, it's this: who are these linchpin roles and what do they do? And the teaser question that we've used and found very effective in a research way, actually, is the very simple one. To not necessarily go to Earl or to Earl's deputy, but to go to Earl's division director, sort of the third layer down in the bureaucracy, the senior program managers, the people, what my friends in West Virginia taught me, they're the weebies. We be here before you came, and we be here after you go. And the weebies are the ones, and you look them in the eye and you say, how many hats do you wear? And they laugh first, but they can tell you, and they can name very precise roles, and those are the organizational critical roles. And we need to really explore that, and that's what this process of succession planning and the research we've done suggests, that it is possible to define those linchpin roles and redesign your workforce and your health department to do its essential functions based on that. I see Dr. Baker and Dr. Taylor here in the audience, both friends and relations, and with Dr. Ranke, they talked about things in the 1970s, I think, of functional analysis with role reallocation. So none of this is really new, but maybe it's just repackaged for today's group. So I'm sure in the discussion time, I'll get you guys to comment. So as a result of working with several consultants, somebody who had just retired from United States Geological Survey, someone who was a dean of business, and a team of the West Virginia WIC program, the Women, Infant, Children program in WIC, was fortunate to have some funding to really look at their succession planning. And so the project I'm about to describe has been a 5-year effort to really look and do a functional analysis of that agency in a statewide system. And out of that, and that advisory group, have come 7 basic steps about how to engage in this. So who are in your senior positions now, these linchpin roles? Who is your real leadership? Who steps up in an emergency? Okay. And what do they do? Sounds simple, but what do they really do? Not what's their job description, not what they tell their supervisor they're doing, but what are they really doing? And how do they do their job? It's the what and the how type of questions. But anticipating the future challenges and how will things change in the future that impact them. And maybe they need to learn something new. And maybe they actually, this is the point that Earl has actually just put into practice like that. Maybe they're people who are really interested and willing and able, and all he has to do is give them an opportunity, and he's got a new leadership person who's really dedicated and will stick with the agency and maybe even work without a pay increase because they're getting more job satisfaction. So you really look at the notion of the talent pools and the talents you need, and then who could step up and how could they be prepared. And then you think about putting into a plan. So actually, I think, Earl, you're living it and you're walking it and you're doing what's right. And it is important to put it down on paper, but maybe that's the last step. So emergency succession planning is actually a continuum that goes from the immediate crisis, because that's what gets our attention and is a Covey Quadrant 1 type activity. You got to do what's on your plate today, but how do we turn that into something that really strengthens overall? So the first type of succession planning is the hit by the bus scenario. Okay. So maybe there's a disaster, H1N1, your kids get sick, your parents get sick, your car has a flat tire. Who's going to step up to the plate? Who's the first person on your cell phone call list that you're calling? Or in West Virginia, folks were really dealing with National Guard or people going on jury duty. How are those handled currently by your organization? You'll find very valuable information. The issue we've been talking about is the issue of downsizing. Business dealt with this last year very much. Government's just now coming to grips with it. But there are ways to deal with it. Or people who quit without notice. And that's the value when Earl's talking about doing exit interviews. Why are people quitting, particularly those who quit without notice? Those are the ones you really want to find out somehow. And they probably won't tell you directly, but you can find out. The second type of succession planning, or there's sort of a continuum, but then the next major jump is into the long-term succession. And this is the phrase there of doing more with less. How do you get by and get the job done and refocus? So you have, quote, normal attrition and retirements. And the estimates of in 3 to 5 years, 40 to 50% of the current public health workers are leaving in terms of the frontline people. And what's going to happen with that? How's that memory going to be captured and kept in the organization? But in governmental public health, we're very used to the issue of unfunded mandates or rapid program expansion. So here we are facing personnel cuts and budget cuts, and someone turns around and says, oh, we've got some succession dollars. Do you want, all this money from the stimulus program? So, it's not uncommon. You're given these huge chunks of money, but they don't give you the infrastructure to go along with it. And how are we creative about doing that? That is actually long-term succession planning. How do you reassemble the jigsaw puzzle? And then there are issues of performance culture and performance issues and organizational culture. We've all been in organizations where there's a lot of deadwood and inertia. And succession planning is, the Peter principle, or, a lateral arabesque was the one I always liked, which is how do you sort of take somebody who's an obstruction and have them feel good, but move them over to the side so the job can get done. When you do that, you're doing succession planning. And ultimately, what we in the field love to see is workforce development and training. We think that what we do at the School of Public Health is important, and we believe in it. But we have to build the business case for doing this. And that's a very tough challenge. I put organizational redesign on there because we neglect the fact that in government, that happens on average every 4 years. And it is amazing to see those changes and how people take a program that's under development. And I always admired the Weebies, the career public health people, who would take this thing that was coming down the pike, and a couple months before the election, it kind of just faded from view, and then it sort of popped up in the transition plans as, well, there's this new initiative, and here's all this data, and it was all repackaged and sold. But that's how it works. And that is another opportunity for succession planning. So these are the core concepts of what we call role-based succession planning. And in the interest of time, I'm not going to go into great detail about them. But I hit the points there about focusing on the senior management. That leadership team is where, in our analysis, we felt it was most critical. And to look at the roles and functions, the people and jobs. And when I was state health officer and had people sitting around the table, hopefully some of whom are listening to this telecast so they can email in and comment about it, but you're a leader there and you're saying, okay, we need to plan for my leaving or for this other thing. And often people, in some organizations, what you hope is they'll all come together and work together as a team, and that's a measure of success. But sometimes there are interpersonal tensions, and people are thinking, what's in it for me? And if he leaves, can I get his job? And how's this going to work? And so if you think about your executive team around the table, and if you then frame succession planning as who's going to sit in whose chair, I think you're doomed at that point. because you've created a mindset where you're thinking about people replacing people and pushing them out, or someone leaving and, oh my God, how am I going to do his job and my job? Or, you know, it all could be good, but as long as you're thinking about people in different chairs, I think you're down the wrong path. If, however, you can get that team to talk about what are the functions that need to be done, and Earl wears 5 hats and Molly wears 7 and Carl wears 3, God forbid, there's some overlap in those hats. So when Earl goes on vacation, Molly picks up, and then when Earl comes back, his job's more fun. Or, you know, maybe there's something he doesn't want to do and someone else wants to pick up and take that on. So how do you create that discussion in your leadership team? And how do you then motivate people? This is just a little series because it's just to bring home this generational thing. We are here because of the work of those who have gone before. But who is it who keeps the public healthy? These are the different types of people who are doing public health now. And they're doing different activities. But who will keep the public healthy when we're gone? And this is the slide where the person said that's actually this Generation Z who's coming in. So a group of us who are not from Generation Z. This was the team in West Virginia, and I really enjoyed working with all of them. But their charge was that more money was not possible. How would they look at the West Virginia WIC system without an infusion of dollars? They did an assessment over several years, and they found that working in WIC is really fun, and they came up with a list of ideas. And one of theirs was to look at a career ladder. How do you build a ladder? How can people climb the ladder? This was an interesting little sub-project. At the state office, there were relatively few employees, which is not uncommon for any program in public health. But they were in 16 different job classifications. This isn't Ford Motor Company, folks. This is not people where, you know, you go out on the street and you hire someone else to build the same widget. We're talking about very specialized skill sets that are dependent on the personality of the person and that have evolved over, in this case, 45 years or more. And how do we redefine what we do? They had actually very low turnover. But when one person left, it happened to be the finance officer for the state agency, they were in big trouble. At the local level, half were high school graduates. And so what we did was partner with American College Testing, the folks that my seniors in high school are very familiar with. And they have a process of job analysis called work keys. And Dave Bell, who's there in the center, would have different subject matter expert meetings. And it's a very structured approach that meets all the proper regulations. And they work through in about 8 very intensive hours. They would take a particular job category and dissect it and say, what do people really do? These people around the table were the ones who were selected for being the best in that area. And it wasn't what was in their job description, he knew that. It wasn't what their supervisors thought they did, he knew that. But the discussion centered around what did they actually do. And you obviously can't read this, but they had on average for each one of those 90 different job tasks, and they separated out the RI-AMLI is issues of locating information, applied mathematics, reading ability. So they dissected which skills were needed as fundamental skills. And I highlighted a couple here because this was just one of the categories for a nutrition assistant, a nutrition paraprofessional that we were actually creating and were still working after several years to get recognized by Division of Personnel. But Division of Personnel likes to see this data. They aren't just saying we need, I mean, we always were saying we need it, but they wanted to actually see the data. What's the person doing? So number 23, at the next to the last line, was providing emotional support to participants such as after breastfeeding failure, stillbirth, or miscarriage. What we identified was that these women who have a high school degree and have been successful mothers with breastfeeding on their own are doing grief counseling. They're often the frontline grief counseling when a mother loses a baby, and it's the breastfeeding coordinator who's sitting there with them, working to do that. That's a very specialized skill. So again, you can't see more here than just the boxes and arrows, but it got more and more complicated, and we created different categories, and we mapped them out, and we showed how, in theory, somebody who is a mom with a successful breastfeeding experience could go through the different classifications, where the training programs were, and they could become the director of a WIC agency for the state with a master's in public health and an MBA. Through this process. They didn't have to go back and start over at the different levels. They could work their way along, or people, what we were interested in was identifying the different talent pools, which are the white bubbles, where we could pull people in to deal with the bottleneck, which is that central box of the nutritionist one. It was the area where we were having our greatest shortage. So you can make this very complicated. And I think we have, those of us who have gotten into research and the competencies and the job analyses and the different work studies and following people along, we get into the work activities, the competencies, the skills, the ability, the knowledge, the attributes. You can get into great detail. At APHA, on the panel with me was Los Angeles County Health Department. And they have not only done that, now they're Los Angeles County, so they have some resources, and they have Jonathan Fielding leading it, but they got into that. They're actually redefining their own set of core competencies and building their job descriptions and their functional analysis from that. But in our analysis, we felt that there's a role for people to do the deep stuff, but for most people in Earl's position, they have to really come across the surface, and they have to learn how to work with their personnel agency and how to talk to their personnel agency, and the personnel agency has to understand the deeper level, and we academics have to understand that. So you need those different things to come together so that the people on the front line can focus on the connection between the jobs and the organizational improvement without having to go into the depths of all of this. For those of you who are more academically inclined, and at the bottom, down in the mud there, is this thing called ONET, which is a national database that if you Google ONET, you find this incredibly rich system that links the worker orientation on the top with the job on the bottom, the occupation on the right, in terms of those cross-occupational skills on your left, and the details of an occupation on your right. And they have looked at all these characteristics, and it's in a downloadable, searchable database with all the proper variables and everything, and it could become a tool that I don't think a practitioner should use, but a consultant could use. Public health doesn't appear in this data set. You can find truck drivers, you can find widget makers, but you can find epidemiologists, but you can't find a public health nurse. Okay? It's just not coded right. Partly because of work with incident command and post 9/11 with the terrorism work that's been happening, one important thing that has been contributed to the public health system from all of that work has been the concept of roles and managing incidents through roles. And so in an incident command structure, you will have an incident commander and these 4 basic roles. You will pre-decide who is going to fill those roles in the event of an emergency. You will write it into their job description, but they will not do that every day. But it is, again, an example of how we are already in public health. We have incorporated role-based planning and redesign, because when the declaration occurs and the incident command center is mobilized, people know what they're supposed to do, and they shift into that role. How do we generalize that? How do we transfer it? And again, we then created a workbook that walks people through these different steps. The first thing in the workbook is, are you ready? If you aren't, don't. And some suggestions about that. suggestions to start small and move methodically and communicate appropriately. And as I was saying, the very first thing is to say, who are the people who are sitting around the table? Who's sitting around the table now? And who's the delegated replacement? This was very hard for people to do. But when they did it, they had done emergency succession planning. That's all. That's it. Fill that table out, you've done it. We obviously took each of those and then started saying, how many hats do you wear? These were the hats that were surfacing from those people in this project. And you can see that program management was something common. HR management was something common, and Earl talked about that. He's talking about training, about how to get along with people, play well with others, professionalism. That is this HR manager type role. We put them through an exercise that's similar to a SWOT analysis of thinking about the roles and the activities and what is going to happen in the future. This is a slight variation called a PEST analysis, which folks enjoyed doing because of the acronym. But to really look at those different components along with the strengths, weaknesses, opportunities, and threats. Oh, customers, gee. Oh, customers are right on the bottom. But you include them. And these are just some recommendations about what we think it does for them. And the purpose of that is to give you the information from the depths of this diagram to turn over to the people who know how to make it work so you don't have to do that. So this is the general recommendations for people like Earl in terms of he's thinking about the feeder pools, he's thinking about the preparation, he's starting to create strategic partnerships with the community college and other folks. And you have to decide. We found a lot of people in local health departments are growing talent for someone else. The WIC agencies recognize that they'll have people working for WIC who then go and get their dietetics registered dietitian and can make better money at the hospital. But hey, they now understand public health, and maybe sometime they'll come back into the public health department. So it's not a bad thing to lose people to another agency. Maybe you infect them with public health principles. And I close here with the whole concept of, what is succession planning? I hope I've touched on the issues of workforce development today and the notion of succession planning and tried to give you a sense today of who's really going to keep the public healthy when you're gone. Thanks. So Molly's going to come up and lead us through the next section.
Great, thank you, both Dr. Taylor and Mr. Stoner, for a great presentation. We now have time for questions and answers, and for those of you watching online, I'd like to remind you that we do have an opportunity for you to email questions into our email address at MAPHTC, that's as in Mid-Atlantic Public Health Training Center, at jhsph.edu. In the meantime, I'll just get started. I know we do have one question that one of our first questions that came in online was about the Certified in Public Health program, and wondering how planners are using the Certified in Public Health, or CPH, to bolster confidence in the public health workforce.
Thanks. I was in the inaugural class and took it because I was interested in how is this useful. I think it's a very important effort. The CPH exam is an attempt to really look at those functions of public health and the skills and the abilities that public health people need, and to give an objective measure of it. And so I took the exam last year and really enjoyed it, found that it was challenging in parts, and parts of it were straightforward. If you know public health, I didn't find it very difficult. And so I would recommend that people who want that external validation of their knowledge set and a standardization across the country will find it very useful. I was teasing Earl here and sort of said, gee, have you done it yet? So
Haven't had time. We have an H1N1 response.
yeah. And so there are barriers to finding the time and for doing it.
Sure.
And
sure.
over time, I think, if, as a health officer, would it influence your decision if somebody had it or not?
I think so. I think that we're now in an age where we have that certification. We're looking at the potential for public health accreditation. That's sort of the buzz now. Really looking at, I wouldn't necessarily say legitimizing ourselves, but from a credential standpoint, having a more professional licensing and licensure type of atmosphere. So I think that, at least from my perspective, and I even do that now, it's, people have MPHs, it doesn't mean that you're the greatest, but certainly you've had some formalized training. And so from my perspective, MPH, CPH, those sort of things would bolster, someone's resume, certainly.
And what I like is it is that verification. It fits with the accreditation sort of mindset and preparation. It's one thing to go to school and have the degree. It's another to have shown your proficiency
Right.
On this sort of exam. And
Right.
that's the way the world's moving. So we'll see how it unfolds.
Okay. We do have questions online, but I just wanted to give our live audience a chance to see if we have any questions here. Yeah, right here.
Question for both of you. Excellent presentation. Really enjoyed it. I'd like to pick up on one word that you used, Dr. Taylor, which was lattice. And as I see it, it's fairly easy to move up the ladder, but across the lattice. See, I'm old-fashioned. I did public health work in New York State back about 100 years ago. And I'd like to know, can you move people, I think in terms of public health nurse, sanitary inspector, and maybe something else. I think there are a lot more professions in public health now than there were 100 years ago. And how do you move people from one to the other? I cannot see a public health nurse moving to be a sanitarian or vice versa. Could you comment on the lattice? I think it's a great idea, but I think more of ladder than lattice.
Yeah, well, that's. Yeah, I'll repeat the question, and then I'll repeat the question and take a stab from theory, but I think Earl will have some comments in practice. So the question was really about the word lattice that I used versus career ladder, and Dr. Baker understands the concept of career ladders and moving up the ladder, but why did we start thinking about a lattice? And the lattice is basically how do you weave those ladders together and what are the points of intersection. So I totally agree, it's particularly for the expert professional disciplines that require a very specific scientific skill set, so nursing, environmental health, are ones that have their own unique knowledge bases, and those ladders stand pretty parallel. At the entry level, I think there is a lot of cross-pollination, and so you might get somebody. One thing we were exploring in West Virginia was that you can, in high school, become a certified water lab quality analyst as a high school student in a vo-tech school, and then you could go on and get your bachelor's and become an environmental health specialist. But we now have enough programs that maybe you aren't an environmental health person as much and you want to do more of the hands-on. So the lattice part would be, in that situation, one single rope that is these bridge programs. Somebody with a bachelor's in another field who could go back for an RN rather than having to go back to college. That's what we wanted to avoid, was having to climb back down the ladder and go up and climb it again. Is there a place, or if there's not, to tell people there's no way you can get there from here. The other place where we found a lot of cross-connection in medicine, nursing, and environmental health in particular is there are three ways of doing work. You do it yourself, or you do it through people, and professionals are good at that. So you're either the worker or the supervisor of the worker. But when you get into that higher level supervision and management, you're doing it through programs and policies. And in that situation, your particular professional expertise doesn't matter. So we found the opportunity in the WIC system where we were facing great shortages of dietitians that you don't have to be a dietitian who becomes a manager. Sure, that would be great, but we were creating an alternate pathway for someone else to move into management with and spare them all of that professional base. So in theory, it was, you're absolutely correct. We aren't trying to dilute the profession for the technical professions, but we're trying to examine in a lattice the crossover points so that we can utilize non-traditional pools of talent.
Well, and I think that just to reiterate, from a local perspective, from a practice perspective, it can be tricky. And I do think that you mentioned those two core functions within public health, you know, sanitation through environmental health and then public health nursing. And Dr. Taylor, just to reiterate what you said, they are on very sort of like parallel ladders. But through some of the theory and through some of the research, there are ways to sort of, like, as you mentioned, cross-pollinate that. And I think that within the state system, and we are, you know, it can be a blessing at times and sort of a curse at times, but our hiring is through the state system. And from a promotional standpoint, it really is. It really encompasses two things. A lot of it's based on how many people you supervise or are going to supervise, and switching to a different area of expertise or a different area within public health. You know, there are people, just speaking of public health nursing, you know, moving up that ladder, if you have people in front of you who are there a while and they're going to be there a while, it can be difficult. So from a career development standpoint, it may cause or take you moving to a different area within public health in order to facilitate that career development. But it can be done, but it can be difficult at the local level. It can be very difficult.
I'll turn it around to you in the audience, though. You've thought about this. Does that make sense, Dr. Baker? I mean, is that this pattern, do you see some pitfalls in that approach?
I think that, as you said, it is limited in its applicability. Basic core functions, which is what I think about, and managers who aren't expert in the field generally get contempt from the people that are working for them. And so I think that a manager of a public health nursing program better damn well be a public health nurse.
Well, and I think to tack on to that, one of the things, at least in my mind, from my view, and what I have been thinking about with this workforce development is, say you have a public health nurse, not to pick on public health nurses, but we keep mentioning them. You have a public health nurse, been there 15 years, say, 20 years. Public health nursing is obviously their expertise and their area of expertise. But if we could develop, and this is just one of the thoughts in my mind, say with the public health practice portion of Hopkins, minimally a certificate program where individuals can go back who have an interest in that broader scope of public health. Sure, I'm a sanitarian, a public health nurse, epidemiologist, but I also have an interest in the overarching idea of public health. Minimally going back and having a certificate from the standpoint of, if I'm going to move up the ladder, you know, I've had some level of formalized training in public health, you know, quote unquote officially, to go in their CV or in their portfolio to sort of facilitate some level of move up that ladder, to give them those core functions and that core knowledge. And also, I guess most importantly from an HR standpoint, that piece of paper that says they've been, you know, formally trained in X, Y, and Z or PD and Q.
Okay. We have a couple more questions online for either Earl Stoner or Henry Taylor. And this is a two-part question, wondering if you could talk about the extent to which accreditation of public health agencies might either help or hurt the ability of the agencies to recruit younger or newer workers. And the second question is, schools like Hopkins have a potential to train newer public health professionals, but a relatively small percentage of graduates go to work for local or state health departments, including environmental health graduates. What do you think about the idea of requiring academic trainees to spend time in public health agencies as part of their training? Would this be good for the agencies?
I think from a local perspective, to tackle the second question first, I think that's an excellent idea. As I mentioned before, mean, we look at public health at many different levels, but when you think of actual public health practice, it happens at the local level. A lot of policy development, regulation, those sorts of things at the higher level, and also some practice. But really, from a practice standpoint, from the practical standpoint, it happens at the local level. And we always welcome the opportunity to work with interns, to work with schools of public health. We have a partnership with Hopkins where we have the preventive medicine residents come up. They don't actually do a rotation or anything, but we at least have them for one day and take them out on site. They go out with sanitarians. They look at perk tests. They look at new wells, problem areas that we may have had, and they also go out with public health nurses and go actually go into homes, go on healthy family visits, and go out and actually sort of put a face to the issue. So from my perspective at the local level, I think it's an excellent idea. That's certainly a push of mine, and I would welcome the opportunity.
Yeah, I think that Hopkins has the potential, and there is actually in Hopkins there are several programs. There's the phase internship where students are placed at the state health department for an experience, and then Mindy Levin and Source and I run a community practicum where students are out in the East Baltimore community. So there are some opportunities, but I totally agree with the person who asked the question that it's a great challenge of how do we really train people to be ready to do the work in those first couple weeks and months on the job. This has been recognized at the national level by the body that accredits schools of public health, says that students upon completion of an MPH have to have had an experience in population health. Hopkins has a lot of people coming in already as mid-career people so that they already have met that requirement. But increasingly, partly to deal with the workforce crisis, we are needing to find placements and ways that students go out and work with field placement sites. And it's not easy. I've been on both ends, and it's hard for a placement site sometimes to deal with students.
Mm-hmm.
Some students are great and fantastic, and other students, you need to have a supportive environment. So there are several programs under the Tom Burke's Office of Public Health Practice and Training and other areas of the school that are really trying to do that very explicitly. It kind of leads to your second question there about accreditation helping or hurting. And I think it's, personally, I have a little mixed view. I mean, I know it is definitely the trend. Accreditation will happen, and it's part of the accountability movement that society wants. So public health has to be accountable. It's not enough to say it's a constitutional mandate, in the state legislature. We have to justify why we do what we do. If it gets into too much of the counting widgets and a simplistic productivity measure, I think that it will be a disservice. It will become more of a burden. If it helps keep frontline people focused on why they're there and explaining why they're there and improving their performance, I think there are ways it could be done. So management theory does have ways it could be done. I do worry that for budgetary and logistic reasons, people might short-circuit accreditation a little bit and miss the true positive impact. So we have to look at it carefully, but it's something that's happening and I think is a good thing overall.
Okay. Go ahead.
I'm a nurse and I work here in the School of Public Health, so I have all sorts of ideas about what you're discussing. Mm-hmm. But I kind of want your thoughts on what you think will happen with healthcare reform and the impact of healthcare reform. There's a lot in there regarding workforce development. As a nurse, I see there's a lot there for nursing, and then also there's the focus on prevention and wellness. But what I'm hearing more so in the whole debate is focusing on more community health centers and federally qualified health centers, and not really hearing departments of health mentioned at all. And I always think of, departments of health as where people would go in need of if they're in need of services. And then at the same time here in Maryland, I'm watching all these budget cuts, and I know people who work for the state who are nurses who, you know, are taking salary reductions and again, all these, and it just seems like this huge disconnect. So here we have the administration focusing on prevention, wellness, and building a workforce, and then in the state of Maryland, we're decreasing the budget for your departments. I hear you're just watched all of these slides on how we need to increase our workforce and you know, build, you know, this pipeline. So I'm kind of curious to what your thoughts are on that.
Well, I don't obviously have all the answers, but I think that the overall concept is, you know, with healthcare reform coming in, with budget shrinking, you know, there's obviously a need to build a workforce, but I think to kind of get at what you were asking from specifically on a nursing perspective, you know, it seems as though there's a focus federally on, you know, through healthcare reform on prevention, but you're seeing a lot of dollars go to, or hearing a lot of dollars that are set to go to, and actually currently are going to federally qualified health centers and not to local health departments. I don't have any real answers on that, but I can say that I do share those concerns that you have mentioned. We have already seen stimulus dollars go to federally qualified health centers and not necessarily come to health departments. But I think ultimately, from a reform standpoint, the focus on prevention is where we need to go. I think in my area of expertise is more that community level, health education, prevention. So I always advocate for prevention. How that will involve local health departments, I don't know. I'm kind of mixed on it. It sounds great, but like, where are we going to be? And I'm all for, you know, basically what's going to be best for the user, in this case for the community. And if, you know, that limits our role, then that's fine. But I definitely think that there still is a role for health departments. I think what you have seen over time is sort of health departments evolve from this core pillar, you know, maternal and child health, public health nursing, sanitation with environmental health, to get into health education and, you know, various and assorted things. But I think what you'll see, especially with the economy the way that it is, downsizing the way that it is, and at least from my perspective at our health department, we're pulling back more toward those kind of like core pillars, and public health nursing obviously being one of those. From the standpoint of how it fits into how the federal level sees health departments, I can't answer that, but I think that there'll always be a role for health departments. Will it be smaller than what we've enjoyed in the past? We could see that, and obviously we are seeing that now. But I think that Dr. Taylor actually you made mention of this, that every 4-year cycle. You know, you see healthcare reform, you know, being the buzz now and being moved forward. Will it be in 4 years, 3 years? You know, what will that buzz be, and where will we be? So,
yeah, in terms of the question of where's public health and healthcare reform, and is our voice being heard, one thing we're fortunate in public health is to have some very strong, clear voices. And in a funny way, public health has been very much on people's radar screens with the H1N1 and the effectiveness, the speed of translation of the field epidemiology on H1N1 and getting the loop back for the actual statistics and the shoe leather epidemiology that's being done by the state and by other folks is really, I think, very impressive because it's been translated into policy. We currently have a seasonal flu vaccine shortage, and people say, oh, it's manufacturing problems. Well, it's a strategic tactical decision in August when the H1N1 was coming on. The companies were asked to shift over to H1N1 production because we have time to get some of the seasonal there. So public health is successful when people don't notice us historically. It's sort of, my wife says, it's sort of like house cleaning, you know, that people will notice if something screws up, but when we work, we aren't noticed. And I think that's somewhat what you're seeing, that we're being effective. We are very fortunate to have some very strong organizations in NACCHO and in ASTO and in APHA and in Public Health Foundation. I mean, there are really just a handful of the national organizations that talk to each other, and I'm assuming they're at the table. I won't speak for them, but I'm pretty sure I've seen indications they're at the table. I also had an observation that, and some people get tired of hearing me say this, but the healthcare reform is about paying for sickness services right now. The title of this lecture and talk and presentation is Who Will Keep the Public Healthy in the Future? And WHO itself said that, you know, health is more than the absence of disease. And our sickness services industry treats a lot of disease and helps people feel better. But it's our job to focus on what is it that is really health and what is the public wanting to be healthy, and how in healthcare reform can we engage in that. So community health centers have had a very shrewd and vocal and very effective effort in this particular healthcare reform effort to advance their cause. And I think that's actually great, because as far as sickness services are concerned and caring for people who are ill, they are the safety net, along with health departments. But health departments are much less involved in direct service provision. The challenge for us is, are we making public health's voice heard? I think we are at the national level, but are we doing it every day? Are we really talking about public health? That little sticker that Molly or Ruth has on her door about, you know, this is public health, is a campaign. So are we advocating for what is public health? And then secondarily, are we partnering at the community level? I started my career in a community health center in West Virginia, and we really blew it, because we came in, there was very high infant mortality. We went out and we got grant money to deal with the infant mortality program, and the health department was, because we're broadcast, I won't say it, but the health department was upset and didn't understand this, and we hadn't gone and talked to the health department. And when we finally did, the county health nurse could name every one of the 6 infants who had died, where they lived, who had been out there on home visits, and why they had died. And yes, it was 6 deaths over a 3-year period, caused us to be the 33rd highest infant mortality in the country in terms of county infant mortality, and we got a grant because of it. But we didn't reach out to the health department. And the health department wasn't really receptive to having us come talk to them. So I will push it back a little bit. As a nurse, you can be a very effective bridge for, at the community level, how do we get all the agencies involved to do those community partnerships? So it's a little bit long-winded, but...
Well, I think that that's an excellent point, not to go on about it, but when you look at the public health system, it's not just the health department. It's your hospitals, it's, you know, nonprofit organizations, it's everyone involved in that. And I think people kind of think of the public health system as just the local health department, the state health department, CDC. It's very broad. It's much broader than that. And so getting partnerships and having effective collaborations is very critical.
Okay, great. I think that wraps it up for today. I want to thank both of you for a great presentation about the public health workforce, and sounds like you're both making great strides to address a lot of the problems that are coming up, and I want to thank all of you for coming today.